Assalamualaikum warahmatullahi wabarakatuh. We are from Group 3 and will present about the roles of IGE in asthma. This is our group members. And this is our table contents, which we will talk about introduction to asthma in IGE, how IGE is produced in asthma, IGE in immediate hypersensitive reaction, chronic effects and role in asthma pathogenesis, and therapeutic targeting of IGE. So now I will explain briefly about asthma and introduction to IGE. What is asthma? According to National Heart, Lung and Blood Institute 2024, asthma is a chronic illness that affects the lungs airways. They also stated that people with asthma may experience wheezing, which is a whistling sound when they breathe out, coughing especially at night or early morning. They also may experience shortness of breath and chest tightness. Asthma may be triggered by allergens, emotional stress, physical activity, infections, certain medicines, and poor air quality. Next, what is IgE? Immunoglobulin E is antibodies produced by immune system and one of the 5 immunoglobulin classes. And under normal conditions, it is the least abundant in the circulation. Its main function are to mediate allergic reaction, protect against parasitic infection, binds to mast cell and basophils via Fc epsilon receptor, and release chemical mediators. Thus, why is it important in asthma? So the majority of asthma patients have elevated circulating IgE levels. Allergic sensitization occurs when specific IgE is produced in response to common inhalant allergens like house dust mites, pollens, animal dander, molds, and cockroach. IgE then produce inflammatory chemical which lead to airways constriction and inflammation.
Next, in allergic asthma, one of the key features is the production of IgE, which is a type of antibody that plays a central role in triggering allergic reactions. In this part, I will explain the immunological steps that leads to IgE production after exposure to an allergen. So it all starts with allergen exposure. So inhaled allergens are taken up by antigen-presenting cells, APC, like dendritic cells in the airways mucosa, for example, pollen and dust mites. Second is the activation of naive T cells. APCs present the allergen to naive CD4 T cells, which differentiate into Th2 cells under the influence of cytokines like interleukin 4. Next is cytokine release. Th2 cells then secrete a specific cytokine, mainly interleukin 4 and interleukin 13. These cytokines play a key role in stimulating B cells. Then, we have class switching in B cells. Interleukin 4 and interleukin 13 will signal the B cells to undergo class switching. So they start producing IgE antibodies instead of other types of antibodies like IgM or IgG. Then lastly is the binding of IgE to mast cells. The IgE antibodies produced are specific to the allergen and bind to the receptors on mast cell. This primes the mast cell for an allergic reaction the next time the person encounters the same allergen. So this is an overview of how IgE is produced in asthma.
Continue on IgE in immediate hypersensitivity reaction. This reaction happens during the second exposure to an allergen after the body has already been sensitized and IgE antibodies are present on mast cells. The next process is called activation phase, when the same allergen enters the body again like pollen, dust or pet dander. It binds to the IgE antibodies that are already attached to Fc epsilon R1 receptor on mast cells. This binding causes the IgE to crossing, which means that the allergen connect two or more IgE molecules together on the mast cell surface. This cross-linking is the trigger that causes the mast cell to become activated. Once activated, the mast cell degranulate and release a burst of chemical mediators such as histamine that cause vasodilation, increase vascular permeability and itching, leukotrienes and prostaglandin that cause bronchoconstriction and mucus secretion, and also cytokines that promote inflammation and recruit more immune cells. After an allergen binds to IgE antibodies on mast cell or basophil, it triggers the release of chemical data like histamine. This process leads to the symptoms we see during an allergic reaction. For the skin, we might see urticaria or hive and eczema. For gastrointestinal system can also react, especially in food allergies, which causing nausea, vomiting, or diarrhea. In the respiratory system, asthma and rhinitis are common, and in severe cases, it can escalate to a life-threatening reaction called anaphylaxis. So these classic symptoms help us identify and manage allergic reactions effectively.
Now, let me continue our presentation with explaining regarding chronic effects of IgE in asthma. The first point will be persistent inflammation, where IgE plays a pivotal role in sustaining chronic airway inflammation in asthma. Upon allergen exposure, IgE binds to high affinity receptors known as Fc epsilon receptor 1 on mast cells and basophils, triggering the release of inflammatory mediators such as histamine, leukotrienes, and cytokines. This cascade recruits eosinophils and perpetuates a Th2 skewed immune response, contributing to ongoing inflammation. The next point would definitely be airway remodeling, where chronic inflammation driven by IgE mediated mechanisms leads to structural changes in the airway, known as airway remodeling. These changes include subepithelial fibrosis, increased smooth muscle mass, goblet cell, hyperplasia, and angiogenesis. Such remodeling contributes to irreversible airflow limitation and reduced responsiveness to standard therapies. Now that we have discussed the two previous points of the chronic effects of IgE in asthma, let me discuss and explain to you regarding the last 2 points. The third one would be bronchial hyperresponsiveness, BHR. IgE-mediated inflammation enhances the sensitivity of the airways to various stimuli, leading to bronchial hyperresponsiveness. This actually increased sensitivity results in exaggerated bronchoconstriction, responses to allergens and irritants, a hallmark of asthma. Last but not least, we will have therapeutic implications, where targeting IgE has therapeutic benefits in managing asthma. Omalizumab, an anti-IgE monoclonal antibody, has been shown to reduce exacerbations and improve control in patients with moderate to severe allergic asthma by neutralizing circulating IgE and preventing its interaction with effector cells. Next, I will be explaining regarding role of IgE in asthma pathogenesis. The first point will be initiation of allergic sensitization. Upon initial exposure to allergens, antigen-presenting cells (APCs) process and present allergenic peptides to naive T helper cells (THO), promoting their differentiation into Th2 cells. These Th2 cells secrete cytokines such as interleukin, IL-4, and IL-13, which drive B cells to undergo class switching and produce allergen-specific IgE antibodies. The synthesized IgE binds to high affinity Fc epsilon receptor 1 on mast cells and basophils, sensitizing them to subsequent exposures. The next point would be immediate hypersensitivity reaction, where the re-exposure to the same allergen leads to cross-linking of bound IgE on sensitized mast cells and basophils, triggering degranulation and the release of mediators such as histamine, prostaglandins, and leukotrienes. These mediators cause bronchoconstriction, increase vascular permeability, mucus secretion, and recruitment of additional inflammatory cells, culminating in the acute symptoms of asthma. The last two roles of IgE in asthma pathogenesis includes the interaction with airway structural cells. Recent studies have highlighted that IgE can directly interact with airway epithelial cells and smooth muscle cells via VC epsilon receptor 1, influencing their function. This interaction can lead to the production of pro-inflammatory cytokines and chemokines. Further amplified one would be therapeutic implications, where understanding IgA's central role in asthma pathogenesis has led to the development of targeted therapies. Omalizumab, a monoclonal antibody against IgE, binds to free IgE, preventing its interaction with Fc epsilon receptor 1 on effector cells. This intervention reduces the frequency of exacerbations and improves asthma control in patients with
Assalamualaikum. My name is Aina Patricia 2310580, and I will explain about therapeutic targeting of IgE in asthma. Firstly, role of IgE. IgE is produced by B cell after allergen exposure, binds to Fc epsilon R1 receptor on mast cell and basophil. Allergen re-exposure causes IgE cross-linking, leading to mast cell degranulation, result in bronchoconstriction, inflammation, and mucus production. Secondly, anti-IgE therapy main goal neutralize free IgE to prevent mast cell activation, reduce allergic inflammation and asthma symptom. Third, omalizumab or Xolair, monoclonal antibody that binds to Fc region of IgE, prevent IgE from attached to Fc epsilon R1 on mast cell or basophil, reduce circulating free IgE and receptor expression. The clinical use of therapeutic targeting of IgE, anti-IgE therapy, particularly with omalizumab, is primarily used for patients suffering from moderate to severe persistent allergic asthma that is not well controlled with standard inhaled corticosteroid. It is indicated in patients who have elevated circulating IgE level and show positive result to skin prick test or radioallergosorbent test for perennial allergens. The treatment is administered via subcutaneous injection, typically every 2 to 4 weeks, with the dosage based on the patient's body weight and baseline IgE levels. One of the major barriers to access is the high cost of the medication, which may limit its widespread use, especially in resource-limited settings. Second, this therapy is effective only for asthma that is driven by IgE-mediated allergic mechanism, meaning it is not suitable for non-allergic to intrinsic asthma phenotypes. Third, treatment requires long-term and regular administration, which can be inconvenient and demands consistent follow-up. Although rare, there is a potential risk of severe hypersensitivity reaction, including anaphylaxis, necessitating monitoring after each injection. For emerging therapies, ligelizumab is a newer generation monoclonal antibody with higher affinity for IgE than omalizumab, and it is currently under investigation for enhanced effectiveness in allergic disease. RNA-based therapy are being developed to inhibit the production of IgE at the genetic level, offering a more upstream and potentially long-lasting approach to the treatment. And lastly, DARPins or design and chirin repeat proteins are novel bioengineered molecules that can target IgE or its receptor with high specificity, representing a promising frontier in asthma immunotherapy. So the benefits of therapeutic targeting of IgE in asthma is patients that receive anti-IgE therapy often experience a significant reduction in the frequency and severity of asthma exacerbation, making their condition more manageable. The treatment also allows for a reduced dependency on oral or inhaled corticosteroid, thereby minimize the potential side effects associated with long-term steroid use. In addition, patients report improvement in lung function, such as increased FEV1 and a better overall quality of life, with enhanced physical activity and fewer asthma-related interruptions.